So I am able to talk a little bit about aspects of physiology and the neuropharmacology. One thing that I often see is that people talk about the pathophysiology of emesis. Actually, this is not pathophysiologic. There's nothing pathologic about getting a foreign substance and having your body react to it. In fact, if you got some of the agents that we just saw and you didn't react to it, it would be very abnormal. So this is normal physiology, really, and emesis is extremely basic. No, a butterfly doesn't vomit. And those of you who are really good can recognize this as a viceroy butterfly. And the viceroy butterfly leads a good life, and birds leave that butterfly alone. And why do they do it? Because as you can tell, this is a different species. This is the monarch butterfly, the monarch and the viceroy. The monarch butterfly has very important on its life cycle, as you can see, is that it's landed on a milkweed plant, which has wobbane. And the monarch butterfly is full of wobbane. The bird eats the monarch butterfly and vomits and never bothers another monarch butterfly or his good friend, the viceroy, who would be very good to eat. So the emesis is such a basic instinct that it leads to avoidance, and it leads to the livelihood of an entire species of butterfly. So this is something that's typical to many, many species, not even just mammals. But we're interested in a particular species of mammal, and we want to control their emesis when people get difficult chemotherapy and easier. So here we look at the red bars are cisplatin, and the bluish bars are anthracycline cyclophosphamide, and these are tough. And if we go back 30 years ago, before there were PD-1 monoclonal antibodies, we controlled emesis for these patients in almost no one, and we hospitalized a lot of these people. 15 years ago, 20 years ago, we had 5-HT3 antagonists and steroids in these areas, and we'd gone from 0 to 60. Half of these people were controlled, and we were awfully pleased by that. But today we can have 80% of these patients without emesis. And of course our goal is to go farther. And a lot of this is based on the fact that the development has used good clinical methodology and has dovetailed with what we know about physiology and pharmacology. It's been important to understand the clinical problem and to understand the physiology and pharmacology. Translational research has gone from the clinic to the lab and from the lab to the clinic, and that's exactly the way we need it. Of course, what's it all about? It's about improving and preserving quality of life. The blue bars using this instrument called the FLIE, and I'll show some more information that's related to this later, show that how patients rated their quality of life immediately prior to chemotherapy, and the red bars show how they rated their quality of life just 3 days later. If they had no CINV, then they rated their quality of life as being just the same. But they had a sudden 1/3 fall off in quality of life if they experienced emesis. So it is a big deal. That is an enormous factor in quality of life to lose over a very short time. So understanding the physiology and pharmacology is important. We need to pay homage to Dr. Borison and McCarthy, who in the 1950s began their development of what really led to the modern role of the physiology of emesis, how human beings, how animals have emesis. And it's really fairly complicated. Of course, the GI tract is involved. Direct irritation to the GI tract can lead to stimulation of vagal afferents, which can go to the spinal cord, which can go to the chemoreceptor trigger zone in the brainstem. And in simple terms, this is very important for emesis. But as time has gone by, we've seen that there's the central and the peripheral activities. If you give a drug or a substance, a chemical such as copper sulfate, it's felt that most of its activity is due to direct irritation, leading to emesis, and certain other things such as apomorphine will react extremely quickly, faster than chemotherapy, and give emesis by a central mechanism. Paul Andrews and others have enlarged on this model, and we know there are so many different ways to have nausea, to have vomiting, and many different centers are involved. But in the middle there, you can see the CTZ, which is the chemoreceptor trigger zone. It's not the chemotherapy receptor trigger zone, it's chemical receptor trigger zone, which is not blocked by the blood-brain barrier. It samples blood, it samples cerebrospinal fluid, and if there are substances that irritate it, that stimulate it, it can lead on a central basis to stimulating what is called the vomiting center deeper in the brainstem, deeper in the brain. The vomiting center is probably not entirely an anatomical structure, but an area, and it has so many areas of output. The fact that we salivate, the fact that different things happen to our diaphragms, to the epiglottis, to the chest muscles, and it's extremely complicated but stereotyped action of vomiting and earlier signals with the nausea. So much of this is involved. It can happen from psychogenic factors, it can happen from chemical factors. Today's ASCO, this month's ASCO, is one of the most targeted therapy meetings that we've ever had. We've understood that you have to know the expression that is important, and it has to be an activating pathway. If a certain receptor is expressed, but it's not an activating pathway, it's not so important. If you understand the mechanism by which the activation occurs, and then if you have a drug that affects that, then that's what we've been talking about so much today in the plenary session and in other sessions today. And that's exactly the rules that have been followed in the development of antiemetics. These are targeted agents that work exactly how we know, with the exception of the corticosteroids, and by blocking known mechanisms, known pathways, we are more successful. This is a list of the usual suspects. The ones in orange to brown, dopamine, serotonin, substance P, are the modern agents, and we know that by interfering with these pathways, we can do well. Now, the dopamine pathway is a little bit obsolete. It still can be useful, but blocking the dopamine pathway was important to much of our thinking, which led to the development of serotonin antagonists. Now, we know that looking at these three pathways, the serotonin pathway, but the type 3 in particular, substance P, and dopamine pathways, that there are specific receptors on the neurons in the brain for these receptors. If you can block them, you can do well. It turns out that metoclopramide blocks the D2 receptor, but when given in high doses, it also blocks the 5-HT3 receptor. It's not as highly specific as the other agents. And we can see that, for instance, granisetron, on this logarithmic scale, its binding affinity is at an 8.4 level, whereas metoclopramide is about 1/60th, only a 60th of that for the 5-HT3, whereas metoclopramide is much stronger for the D2. So if metoclopramide is given in excess, it can still have activity on the 5-HT3 receptor. But why not have more specific and selective drugs, which is exactly what we have? Those stained granules are serotonin in the enterochromaffin cell, which are in the duodenum, and the upper GI tract has the majority of the body's serotonin. In fact, right next to those, across in the lower right, is the synapse, where you can see the receptors for the vagal afferent nerves. It probably doesn't require a lot of serotonin, although sometimes that's released, to stimulate those vagal afferents, and then give us the central effect. So it is widely known that the serotonin antagonist can work in the gut, right where the receptors are, or they can work centrally in the brain. So either one of those can be helpful. So there's a little cartoon with a circle there that shows that exact same activity. But if you look in the yellow to the right, where it says chemoreceptor trigger zone, you can see that that area in the area postrema of the brainstem has many different neurotransmitter receptors, including just the ones we've been talking about. We know that the NK1 receptor antagonist must get into the brain to be effective, whereas the serotonin receptor antagonists do not have to get into the brain to be effective. They can be effective peripherally, although they can also work in the brain. This is a photograph, X-ray crystallography of the 5-HT3 receptor, transmembranic, ion-gated, and if you look at it more closely from up above, it has 5 subunits. No other serotonin receptor has 5 subunits, such as this one has. So it's important to recognize that. Now, most human beings have alpha and beta units of a total of 5 of them that make this up, usually 2 alpha and 3 beta. And you can see from this cartoon that between the A and the B, the alpha and the beta is where you get binding of a serotonin antagonist on this receptor, which then is where serotonin binds, and you get this blocking of this by the 5-HT3 antagonist. We know that there are different affinities for the receptor by different drugs. Ondansetron, granisetron, dolasetron, very similar at 8 on this logarithmic scale. Palonosetron, 100 times the binding at this, which is interesting. I'm not going to talk about the clinical effects. Now, we also know that we can detect that different people have different polymorphisms for the beta, for the gene that codes for the beta subunit of the 5-HT3 receptor. If you have the wild type on both alleles, you have the greatest chance of good control. If on the other hand you are homozygous for this deletion, then that's the bar where there's deletion from both the contribution of the mother and the father, and those people have the poorest control. And if you're heterozygous, it's in between. This is also an argument for combined therapy of different pathways to lead to the best control in case you're one of the few people who has this genetic abnormality. This is not to say there aren't more, and also not to say as we get closer to doing whole genome samples or genetic analyses of 50, 100, 200 genes, that knowing this wouldn't be a useful outcome as well. We know from meta-analyses, and one was done by our chairman, not this one, Dr. Hesketh, that the corticosteroids decrease by a relative factor of 50% a single dose in acute emesis and are helpful in delayed emesis. So it's very interesting, but we're really not sure, and it's quite controversial how corticosteroids work. So for dopamine receptor antagonists, we have metoclopramide, haloperidol as 2, but metoclopramide's the one that also hits the 5-HT3 receptor. Here are 5 of the many 5-HT3 receptors that are approved, and we now have 2 approved NK1 antagonists and 1 investigational NK1 antagonist as well. If we look at how NK1 antagonists work, we can see that they have a broad spectrum of activity. You can see all those X's under that column, NK1, whereas dopamine and 5-HT3 don't work as broadly. That's not to say that as individual drugs they work better, it's just to say that they work in many different emetic presentations. So we know that if you have a brain scan made by a PET scan with a tracer that binds to the NK1, that upper yellow image, you get high binding throughout the brain and in some specific locations of this tracer for an NK1. And we know if you give aprepitant or rolapitant or nitupitant, you will get a cold brain scan and you'll actually block in the brain those receptors. I don't know if that yellow line comes across, but really what's important is that column. That is the blood level that we're able to achieve with these drugs that blocks 90 to 95% of the receptors and gives a good clinical result. So corticosteroids have high value in acute and delayed. Serotonin antagonists are a cornerstone of treatment in many, many settings, and NK1 receptor antagonists are important additive agents. This is a study that I selected for a reason, looking at the rolapitant HEC1 trial, which was recently presented at ESMO. What I'd like you to look at is that the control of Emesis, pretty high in these people receiving cisplatin, for the 3-drug regimen, including rolapitant, is better than that in the control group, significantly. Also, you see that adding the NK1 improves the no nausea rate, but please notice that the control of nausea lags behind the control of vomiting. We can see that with NEPA, nitupetant palinositron, which was recently approved at the end of 2014, and you can see in the NEPA arm that the no vomiting rate is better than the no nausea rate, and in the control arm of PaloIndex, we see that that is also true. So this is a very consistent finding that the control of vomiting exceeds the control of nausea. If we look at the impact on daily living, we can see that the NK1 receptor combination, in this case the NEPA, improves not only the no nausea rate, but it also improves the impact on daily living. So we know that vomiting control exceeds nausea control, but there's a strong correlation between the two. Nausea may involve more neurotransmitters, this is a hypothesis, than does vomiting. And the anti-nausea effects of antiemetics may work as a hypothesis, a second hypothesis, by reducing nausea. I'd like to discuss that with you. Or maybe both of these work. So this is the way I see it. In different species, we have different different rates of ease of vomiting. So everybody who has a dog knows it's difficult to keep a dog from vomiting, but rats probably cannot really even vomit. So we're in the middle as a species. For some reason, men are more resistant to emesis than women. And this is true no matter what the stimulus, postoperative, motion sickness, etc. So it's really not so surprising. So does nausea lead to vomiting? I believe that there's a perceptible nausea level and that there are certain activities that occur before you perceive nausea, and some of these have been shown, such as gastric stasis or anorexia. Then you have a vomiting threshold which is higher than this nausea threshold. So as the nausea stimulus increases, you perceive the nausea, and as that stimulus gets even stronger, it can lead to vomiting. These thresholds may change throughout life. So if we look over time, there could be a weak stimulus that doesn't even cause nausea, but physiologic events such as gastric stasis are occurring. As it strengthens, you feel nausea, and you may be in that unpleasant nauseated stage for quite a while with no vomiting. And then it may cross the vomiting threshold and vomiting occurs. Another stimulus may go right through nausea for a short time and then to vomiting, and it may occur in a really strong stimulus that the time in just having nausea is so short that you don't even perceive nausea before the vomiting occurs. So it is my contention that nausea leads to vomiting here in this model. That the way antiemetics work is that you would, in patient 1, have a stimulus that's strong enough to produce vomiting, but the antiemetic may reduce that to a level below even perceptible nausea level, so it's a very successful prevention of emesis. On the other hand, in patient 2, the antiemetic may reduce the stimulus so that you don't vomit, we get a no vomiting result, but the patient continues to have nausea. So I believe that this may explain several different things. Why the control of nausea is consistently less than the control of vomiting, that available antiemetic agents decrease nausea as well as vomiting, just not as well, and because there's that long area above the nausea threshold. Because we have more nausea, it is appropriate to have the primary endpoint in our trials as the control of nausea. So progress in the control of emesis that we'll hear about from my colleagues has been made by the use of evidence from good clinical trials and good basic trials, that we have a lot of evidence in this area. Translational research has gone in both directions. The current treatment is based on a sound understanding of physiology and neuropharmacology, and future research needs to build on increasing this understanding.